Welcome to Moving Conversations, a podcast for movement professionals by movement professionals. If you coach, train, or teach movement, Pilates, or fitness, then this podcast is for you. With more than 60 years of experience in fitness and Pilates, your hosts, Brian Ritchie and Nora St. John, explore the science of human movement, diving deep into the facts, myths, and common misconceptions, hoping to spark thought and conversation about how we view fitness and movement. Now, let's jump into Moving Conversations. Welcome back to another edition of Moving Conversations. I'm Brian Ritchie, and joining me as always, the one and only Nora St. John.
Welcome everyone, happy to have you here with us today.
And today, we've been talking about low back pain occasionally throughout the podcast, and we thought we'd do a little bit more on that. We're going to talk about disc issues, and even more importantly is sciatica.
Whenever I teach classes on the low back or talk to people about low back, the one question I always get is, what do I do about sciatica? Always.
Yes.
What is it? How do I deal with it? It's always a question. So we thought we'd take some time and see if we can provide a little insight to that tricky little condition.
Well, what's interesting about it that I've always found is it's sort of a condition that a doctor will tell you, well, you have sciatica, and then leave it at that. And no one really explains it to, the patient, the consumer, however you want to put the term, but they don't really understand what it is. And so they come to us and they say, well, I have sciatic pain. But they don't know anything beyond that.
Well, sciatica is literally a symptom.
Yes.
It's not necessarily like it is a symptom that means that the sciatic nerve is irritated. What that diagnosis doesn't tell you is why it's irritated or what might be causing the issue at hand.
Yeah.
And that's the challenge. It's like saying you have back pain. That's not really very helpful. Like, okay, I could have told you that, but it doesn't tell you why. It doesn't really give you a lot of information about what to do about it.
Absolutely. I've always called it a garbage diagnosis because and that's what it's referred to in the industry as, is because it doesn't tell you what causes it. And if you don't know what causes it, you really have no idea about what to do about it.
Right. I mean, symptom versus pathology. You can see I have symptoms all day long, like my right leg hurts. That's not a diagnosis.
No.
That's information that's useful, that could lead you to a diagnosis, could lead you to some understanding of a pathology that's happening. But just saying my leg hurts, or, I have tingling in my right leg, or I have numbness in my right foot, which are oftentimes a symptom of sciatica, that doesn't really tell you much beyond that there's a symptom there that needs to be explored further to find the diagnosis.
Yes. And I mean, we can do a rundown. The things that can cause sciatica could be anything from a disc herniation or a bulge, spondylolisthesis, SI joint dysfunction, piriformis syndrome. The list goes on and on and on. And it could be any of these things. And each one, we have to, as a fitness professional or a Pilates professional, we are going to work with the person a little bit differently to help manage that. But to say, oh, I have sciatic pain doesn't tell us anything.
Right. So for example, but sciatica is an inflammation or irritation of some kind of the sciatic nerve. The sciatic nerve comes out of several different segments of the lumbar spine, comes into through the sacral foramen, and then merges into one nerve that basically then goes down and innervates the lower leg, branching out again as it goes into the leg. And it primarily affects the back of the leg, the hamstrings, into the calf, and into the foot. It doesn't really necessarily affect the front of the leg. So if somebody's got front of the leg pain, it's not necessarily the sciatic nerve that's going to be the issue there.
What I do find for the sciatic nerve is occasionally we see it go into the inner thigh. So it doesn't just stay in the posterior. So we'll see it in the inner thigh, and almost a wraparound effect that'll go down into the knee. And I mean, we can get into dermatomes in a minute, so we can actually see roughly where you may be having the impingement. For us, as in my practice, a lot of times, someone will tell me that they have the numbness, tingling, radiating pain. And for me to know where the pain is, where the numbness is crucial, because that will tell me so much about what's going on and give me more of an indication of, okay, how am I going to work with this person? Is it coming from the glutes? Is it coming from a piriformis? Or is it coming from the low back?
Yeah.
because those will sort of play off each other differently, and the symptomology will be different.
So let's talk first about it coming from the back. So typically if it's coming from the spine, the issue is that there is some kind of pressure on that nerve, either from a disc, if it's a disc problem, or it can also be from a stenosis or from some other structural issue, which is compressing the nerves that come out of the central nervous system, or that come off of into the canals there.
Yeah, so where the nerves are branching off from the central canal through the intervertebral foramen, we can often see, like you said, a lateral stenosis of some sort, where it's clamping down and impinging on that nerve and sort of disrupting, almost like a water hose. You kink it, and you're going to get
Right.
less water coming through it. So that's kind of an easy way to think about it. You're compressing the area, and you're either stopping that electricity, that flow, or you're impinging it, creating, not allowing enough to go through.
Right. And the challenge with that is, I've lost you. There we go. And the challenge with that is that if, let's say, for example, that's where it's coming from, and sciatica is coming from the spine itself, if it's a disc problem versus a stenosis or a spondy problem, something else that's causing it, those are two very different strategies that we typically use to address a low back pain.
Yes.
So it's another case where really sciatica, if it's not helpful unless you know something about where it's coming from. And then a third or another common situation with it, maybe not common, but that sometimes happens, is an impingement just in the muscles, the piriformis syndrome, or it's SI joint, but really it's the piriformis that will typically clamp down on it and cause an impingement through muscular tension. Very different than having it be a bony impingement or a disc impingement onto the nerve.
Absolutely. And for us, I'd almost rather have someone with it being affected by muscular, because that seems to relax a lot faster. We can get it to release through some self-myofascial, release, small ball, foam roller, whatever you use, or send them to a good massage therapist or physical therapist. They can get that to release a lot quicker than you can if you have a disc herniation, or if you have something like a spondy that is structural versus muscular.
Right. You also have some easy ways to provide self-care.
Yes.
Once you teach somebody how to release their glutes, again, with a ball or a roller or a manual therapist, oftentimes that will take care of it. And then, they know if the symptoms come back, they do the release again and it goes away. And just to complicate things slightly, I have found that sciatica, even if it is coming from the spinal issue, from a disc problem or something else, will sometimes lead to the piriformis being tight. You almost have a double whammy.
Absolutely.
And sometimes then releasing the piriformis can at least ease up the symptoms or release the symptoms, even if they're primarily coming from the spine, or at least an aspect of them is coming from the spine. So it's always that whole chain you've got to look at.
And we see that. We see when someone has muscular tension, spasm, or something in the low back, how it can become referred into the hip, going down into the glutes, and they'll almost have a radiating pain within the glutes themselves, where they're going to say that's what's really hurting, even though it may be coming from the low back, and we can see the tightness in the low back, and you can see that they're not moving properly. But where they may be experiencing the tightness and the muscle spasm may be just in the glutes, may be in the piriformis. So doing the self-care, doing the release work can relieve a lot of things. And I'm sure you've had this happen, where if you teach the client how to take care of themselves, when it does come back, either they're going to remember it, or they're going to call you and say, what should I do? And all you have to say is, oh yeah, hop on the phone. Oh yeah, that's right. And they can start helping themselves get better. You put it in their hands rather than needing to go to the doctor each time or get on drugs or whatever else.
Yeah. Exactly. So sciatica, just to talk about sciatica, the challenge here is you compressed a nerve. And the things about nerves is that, like the sciatic nerve especially, because it's quite large, and it includes both motor issues, right, motor control, so muscular feedback, and also sensory feedback. So both of those things are happening. So symptoms can be quite variable. It can be in a severe case, loss of function like foot drop or other kinds of loss of strength in the muscles. That's a more severe case. More commonly, it can simply be tingling, numbness, sharp feelings of like pain that shoot down the leg. It can be in the glutes. It can be in the back of the leg. It can be in the calf. It can be in the foot. More than once, I've had a client who had a lot of foot pain. And so the podiatrist was treating them with orthotics and all kinds of things. It wasn't making any difference. And it wasn't the foot. It was coming from the spine. It was coming from the sciatic nerve. So that's the other thing, too, is that the symptoms are not localized to the area of that is really the problem, right? You won't necessarily have low back pain with sciatica.
And the thing that the story you just told, I'm going to mention, I had a client who had something very similar, except for what he had was, I'm going to say this first, he was a diabetic. So that puts
right.
an overarching, theme to this. So because he was a diabetic, he suddenly couldn't go upstairs. He had no pain, but he started losing function in his leg. And of course, they're thinking about peripheral neuropathy. They're going immediately to the look at the, what could it be with the diabetes?
Right.
And he kept going to doctor after doctor. This lasted 6 months.
Wow.
Finally, his wife said, "Why don't you go see my rheumatologist?" And he's like, "Why? It has nothing." He said, "Just go and see her and see what happens." Sitting with the rheumatologist looks and says, "Turn your head to the left. Turn your head to the right." "Okay, you have arthritis. That's what's causing your leg." And he said,
Right.
"What do you mean?" And sure enough, by having a differential diagnosis, by looking at it from a different point of view, again, the overarching theme was the diabetes, and he was furious that nobody else looked at this. How it was explained, and I talked to the doctor about this, they say, look, the nerve itself has multiple layers. There's a sensory layer, which gives you the numbness, tingling, radiating pain, and that's more on the outside of the nerve. The central portion of the nerve is more of the muscular component. Some people bypass the sensory component, go right to the muscular, so all of a sudden he couldn't use his right leg to go up and down stairs, and he's frustrated, and this is a guy who hiked all the time, and he was super strong, but all of a sudden couldn't use his leg. So again, getting the correct diagnosis made a huge difference. And it tells you that not everybody's going to have the same symptomology. You're not always going to have it start with the numbness, tingling, radiating pain. It might, but it may not.
It may not. And even with that, I mean, one of the things I often say is every client who has pain of any kind, it's like they create their own unique vocabulary. Yeah. There's very few clients that have expressed their pain the same way as another client.
Mm-hmm.
And with sciatica, that is especially true. One other thing I like to say about it being nervous tissue, as opposed to, bony tissue or muscular tissue with sciatica is, and this is when I start to treat people with it, nerves have memory, which is an annoying thing about them.
Yeah, they
so
do.
once you irritate it, let's say you're working with a client, we'll talk more about that in a minute, but once you irritate it, it can often stay irritated for a while.
Mm-hmm.
So one of the key things, working with sciatica is trying not to create an exacerbation, right? Other symptoms, like you'll push through certain muscle things, you'll push through some tendon tightnesses and things like that, or range of motion issues, you may push through a bit. Sciatica, you really don't want to push through and cause inflammation, irritation, because it will then flare up and takes a while sometimes to calm down.
I have that happen occasionally. I've got multiple disc herniations in my back, and once every great while, this happened a year ago, and I'm still dealing with it, where I did something silly. The discs shifted out, and we'll talk about herniations in a minute, but I got that impingement, and immediately, numbness, tingling, radiating pain all the way down to my big toe on my right leg. I knew exactly what it was, and even when it calmed down, even when things calmed down, if I stretched just a certain way, that numbness and tingling would come back. And it was just the nerve, especially a hamstring stretch, which tractions that nerve just enough that suddenly it sort of wakes it up and it says, hey, remember me? Yeah, pay attention to me a little bit.
Exactly.
And and again, it happens occasionally, but that will happen. It will happen from time to time with a client. And you have to just remind them that, oh, okay, it's talking to you a little bit. Don't overemphasize it. Oh my gosh, you really, ooh, you must have done something bad. No, it's like, okay, let's see if it'll calm down in, a little while. Mine usually will calm down in, 30, 40 minutes if I've just done it through stretching. And I'll just say, oh yeah, I feel that. And it does calm itself down. It's when it doesn't that you might have to go a little deeper.
Yeah. So disc issues.
Yep.
Let's go back to the central root here. So with a disc problem, and this is also speaks a little bit to, again, the mechanics of the injury, the pathomechanics, if you will, of the injury. So if it is coming from the spine and it is disc related, remember, disc is a nice cushion kind of thing with a fibrous outside and a squishy middle. The famous jelly donut analogy will often go well here. And with a disruption of a disc, it can just get loose so that it starts to squish out beyond the walls or on the edges of the vertebra. And that can, of course, be just minor bulge, or it can be more of a more permanent bulge, or it can actually break through the wall of the disc, and you can actually have the disc tissue, the annulus fibrosus, the inner jelly, if you will, starting to float up and down inside the spinal canal. And in any of those circumstances, that disc can move in any direction. Again, with sciatica, it's typically moving towards the back of the spine because that's where the nerves are. If the disc is bulging towards the front of the spine, there's not a lot of, the spinal cord isn't there, so you're not going to have the same nerve issues.
Right.
But it can also then, of course, move to one side. Typically, sciatica will be more one-sided than another. So it's not just bulging, but it'll typically bulge more to one side.
Yeah. And if you think about the structure of the ligament structures of the spine itself, you have the anterior longitudinal ligament on the anterior portion of the bodies of the vertebrae. So that's actually going to hold that disc in. And so rarely do you hear about a bulging disc or even a herniated disc going forward because you've sort of got this big wall of spackle on the front that's holding it in place. It's like, look, you can't get past this that easily. Whereas in the back, the posterior longitudinal ligament, because of where the pedicles are, those bone, where the posterior portion of the vertebrae sort of lie, you have almost a diamond shape with the posterior longitudinal ligament. So it gives itself, it lends itself to having room and areas for that disc to sort of sneak out and sort of to sneak around it. And that's when you get into trouble because that does become that quote unquote posterior, lateral, disc bulge or disc herniation that we're going to see in the MRI reports.
Right. So if that's pushing, and again, that can put pressure on the nerve, either again, just the surface of the nerve and get more, and again, depending on which part of the nerve it's impinging on, that will do two things. One, it'll tell you what kind of symptoms they have, as you said, motor or more sensory, but it'll also say where that's coming from.
Yes.
So one of the things that is something we talk about with sciatica and with particularly, any kind of sciatica, is dermatomes. So trying to figure out where the pain is where the nerve pathway is. So where the pain follows, that will also be related to a specific level of the vertebra, which may lead you to understand where the problem is coming from.
Yeah. Yeah. What I've personally have is a couple of different things, but one is my big toe. The medial aspect of it is always numb, has been for 10, 15 years. And once you learn about the dermatomes, you realize, oh, L5S1, well, that does affect that area. So for me, I know, okay, that's one of my areas that I've got a little bit more compression there. Just slight amount. It doesn't bother me much, but it's definitely there. And I find that is the case with a number of people where they say, oh yeah, I don't really feel my big toe, especially during an exercise. We say, maybe push through your big toe a little bit. They say, yeah, I don't really feel that much. So that might tell you something that they're getting. I don't want to call it neuropathy. It's not. It's just a disruption of that sensory. So they're not feeling it as much. But if they feel it in the lateral calf, if they feel it in the inner thigh, if they feel it up in the hip, can really tell us as the professionals, where exactly they may be having the impingement, or is it a multi-level impingement?
Right. And sometimes, I'm going to throw this out there because I'm not really sure if this is true, but when something is more related to a piriformis tightness, so the sciatic nerve, again, comes from several branches through the lumbar vertebra and the sacral vertebra, even though they aren't really fused. And then it merges together into pretty much one nerve as it goes through the piriformis, or more or less. I'm sure there's variations on that. And it can go either underneath the piriformis or go through the piriformis. And that's kind of the challenge there. So there you have all of those nerves, all of those areas coming through one area and getting impinged when it is basically all combined, is what I'm trying to say. Right. So that can lead to a wide variety of different symptoms because you have all the nerves that are then going to innervate the entire lower leg, or at least the whole posterior chain of the lower leg. And that can cause some real interesting things about piriformis syndrome. It doesn't follow the dermatomes as closely, I guess is what I'm trying to say.
Right.
Or doesn't necessarily follow the dermatomes so much.
I've noticed the same thing. That if we have a direct impingement, I can look on the MRI and see, oh, it's L3, L4. Okay, and I'll ask, where do you say you have numbness, tingling, radiating pain. They're going to point right to, the inner thigh or the back of the hamstring. They're going to point right to the upper thigh portion. Whereas if it's L4, we're going to see, oh, okay, it's more lateral calf. If it's L5, oh, it's going to be in, the big toe. You're right. That is a lot more specific than the generalized all the way down my leg or multiple points down my leg, which it could be if you have multi-level issues. But yeah, I've seen the same thing. If it's more the clamping down muscularly, we see more of a generalized sciatica going down the leg.
Yeah, and sometimes it's more variable. It'll switch a little bit from the lateral thigh to the back of the thigh to the inner calf some funkiness there. So when we're dealing with somebody with sciatica, like, what do we do? Where do we go with that? I think the first thing, which you've certainly mentioned, is if there is a diagnosis, and that's a big if, I know that, but if there's a diagnosis, then it's looking at going back to our basic low back issues of, if it's a disc issue, we want to focus on neutral towards an extension bias, potentially. If it's something more bony, arthritis or stenosis or spondylolisthesis or spondylolysis, we're generally going to start thinking about being more in lumbar flexion, neutral towards lumbar flexion. Which again, if you don't know what it is, you're going to try one or the other and see how you do and experiment until you figure out if one makes things better and one makes things worse.
And something that I found is, if they've worked with a physical therapist or a physician, I mean, how many times have we talked? Person comes in, we talk, we do their medical history, and I've got low back pain. Say, well, is there a diagnosis? Yeah, I just don't remember what it is. And so the thing
or they've never been given it.
Right, or they aren't given it, exactly. But if they've worked with a physician or especially a physical therapist, that's what I'll ask. I'll say, oh, when you're doing your exercises, were you in a flat back position? Or did they have you really arch up a lot? Because that's going to tell me which it probably is. Because if they say, oh, I was doing a lot of arching, we'll talk about this in a minute, the McKinsey exercises, where I'm doing a lot of arching of my back, immediately I think, okay, that's more discogenic. That's going to be more toward the herniation, bulging disc side of things. Okay, so I can continue those type of exercises with the client. If they say, oh, yeah, I was with a flat back the whole time, they didn't want me, they wanted me imprinted, okay, cool. That'll tell me, let's focus more on that side of things.
If they've been to a PT before you.
Right, exactly.
And if they've been getting any exercises. I know when I was working at St. Francis, we very, very, very often got clients where they bring in their script, their prescription pad, and they would just say, diagnosis, low back pain.
Right.
And they wouldn't have seen a PT necessarily in our case, or maybe they'd seen them once, but they didn't get a very specific exercise program. So then you've really got to, be the body detective.
100%.
You've got to do the detective work, and you've really, in some ways, got to do. I don't want to call it diagnosis because that's not what we get to do, but we've certainly got to do some problem solving and some understanding of what's happening in there.
Well, and that just makes sense that when you get someone for the first time, if they don't have a diagnosis, but they have experience with a lot of low back pain, I think the first thing is, what I often ask is, what makes it feel better and what makes it feel worse?
Right.
If
Right.
standing makes it feel better and sitting makes it feel worse, well, guess what? Flexion may not be for you. Or, man, when I sit down, I feel so much better. Okay, flexion seems to be better. So just asking the right questions sometimes can, get the answer that you need on where we want to focus their exercise prescription, so to speak.
Right. Step one of body detective, right,
Mm-hmm.
is what can you do, what can you not do, what causes pain, what doesn't cause pain. Do you know? And a lot of clients can tell you things like that.
Mm-hmm.
I really hurt after I've been sitting at my desk I can sit at my desk for about 2 hours, then my back really hurts, my leg starts to go numb, for
Yep.
example. Okay, flexion, probably not a good thing because very few people sit in their chairs in extension, you know. Or, I can't stand for long. Every time I stand up, my back really starts to hurt. Or I have a standing job and I have to sit down every 15 minutes. Then it's like, okay, so generally in standing, not everybody, but most people are a little more towards extension and compression. So those will give you some clues. Yeah, you always got to look for clues in this business. It's always about what are they saying? What does that mean?
No question about that. And I find that they know the answers. You just have to ask the right questions.
You got to dig. Sometimes you
Yep.
got to dig.
Yep.
Yeah,
And
and really be specific.
even if it's just, okay, they can't answer those questions, you can just have them lie down on their back.
Yeah.
Okay, flatten your back. Does that make things feel better or worse? I had a client who, she said she only has this little mild hip discomfort. She has one hip is higher than the other, mild. She lies down, goes into a bridge flat and causes a flat back position, more of an articulating bridge. And suddenly she gets nerve pain down her leg.
Uh-huh.
But she didn't have that before, but she was never asked to do that necessarily. So,
right.
And we, come to find out she had spondylolisthesis, a disc herniation, and stenosis. So it's like, oh, okay.
There you go.
Well, now this answers some questions here. We now have, we have a lot to work with. But again, it's by experimenting sometimes gently. I'm not going to ask them to do something crazy, but just lying on your back, flatten your back. Does that feel better or worse? Arch your back a little bit. Does that feel better or worse?
Yeah. Yeah, exactly. So, in some ways, starting with simple, either supine, which can be fine, or if they can tolerate it, a little cat-cow.
Yep.
Just being on all fours, because most people can tolerate that. It's pretty gentle flexion and extension work for them. And it's like, okay, you notice like they don't go into extension at all. They basically will round the back and then they'll go to neutral, right? And ask them, like, does it hurt if you go any farther? It's like, oh, yeah, right. I don't want to go any farther than that. That gives you a clue. Or they really don't round very much, right? They really maybe they round through their thoracic, but they don't really move their lumbar much. So again, all those different ways to just kind of get a sense of, would it be more of a flexion bias? Would it be more of an extension bias? And that, with any low back pain, that's often step one about where you're trying to go and what general direction you're going to take.
And what was interesting, what you just said, if they're sort of avoiding something, we have a term called apprehension sign, where you can see it in their face. We've all seen it with the client, that you ask them to do something and you can see that there's apprehension. You can see that they're squinting. They're either trying to avoid pain or they're waiting for the pain. It's about to be here. It's coming. And you can see that in a cat-cow, where if they go into flexion, no problem. They go into extension. If you can see their face, you'll see them grimace a little bit as they get close to the spot, even if they don't feel it yet.
Yep.
It's that anticipatory pain is going to come now.
Yep. Just watching their faces, right? Watching their faces, watching their body tension. And we talked about this yesterday. We were talking a little bit about this, other things yesterday. This is a situation where I don't give them a lot of cues. Yep. If I'm trying to see what their reaction is, I'm just going to give them basic, like, how do you do this is the movement we're going to do it. I don't give them a lot of refining cues or anything like that, because I just want to see what their reaction is. Yep. I don't want them to be making me happy. I want them to just be moving like they usually do so I can see their strategy.
Yep. Absolutely. Yeah, when we spoke before, the more cues you give, the more their brain gets involved, and you're not necessarily going to see what's natural.
Right.
And
what they do when you're not thinking about it.
Right. We want that natural, not thinking about it. How does their body just move in space? And that's when you will see the avoidance. You're going to see the apprehension. You're going to see them not want to go through certain ranges of motion. and my thing is respect that,
Yeah.
because their body's
Especially
going to tell you.
Yeah.
Their body's definitely going to tell you. When we were, together almost a month ago, I was working with someone and they wanted me to do a certain exercise, seated lateral flexion. Well, I know my discs really don't like that. And that's the fastest way for my disc to reherniate itself. So I immediately said, no, no, no. Because I know my body. And I know that even if I tried it, I know how stiff my body becomes when I get in that position, because I have that PTSD almost. Just within my body. It's not even my brain telling me. My body is telling me, yeah, we really don't want to do this. We really don't want to do this. And if you see that in someone, we do want to respect that. And that may be a range of motion to, down the road when they're more comfortable and their body is moving better and things, we may want to approach and see if they can do a little bit more. But if they have that apprehension, we really need to respect that.
Especially when you first get to know a client, because so often if a client's in pain, and especially if a client's in pain and they've perhaps seen a variety of different practitioners who have maybe they haven't had the best results from them, right? So they're nervous anyway, right? They're coming to see you. They've not had good experiences so far, or maybe they just have had neutral experiences so far. Nothing's really helped. You've got to get their trust, and they're not going to trust you if you cause pain right off the bat,
right,
or you ask them to do things that they really clearly are not comfortable doing. Now, when we think about managing sciatica, what are we trying to do? Like, what are we trying to get to in terms of decreasing the pressure on that nerve? What are kind of our strategies for that?
Well, for someone with a disc herniation, we really, and I'm going to say this as an overarching thing, when we're talking about a disc herniation, we're talking about only a disc herniation right now. Okay, no additional things. They don't have stenosis. They don't have something else, because that can be a different strategy. So if it's just a disc herniation, we want to put them into more of an extension. We want to get pressure off of that, because when we talk about that jelly donut, if the jelly is being squished out one side, what do we want to do? We want to push it back in toward the opposite side. And by doing extension, we're really taking that disc and moving it back into, the healthy place that the disc should be, the nucleus, I should say, within the disc. So take it out of the joint space, push it forward back into the disc, and hopefully decompress that disc, or decompress the disc and decompress that nerve root that's coming out into the intervertebral foramen.
So extension is typically our first, again, if it's pure disc, because if it's disc plus arthritis or disc plus, because it's often a combination of things, it just gets much more complicated. But exactly. So, and the other thing too that can help sometimes, and again, this isn't your case, but for some clients, again, if the disc is typically coming out one side, so sciatica on, let's say, the right side, sometimes a side bend to or away from that side, I find both can work depending on the body, right, can do the same thing. It'll kind of squeeze that nucleus pulposus and pull it, centralize it essentially, right, pull it back in towards the center of the disc and decrease that pressure.
Yep.
But usually extension is where I start, because it's usually simpler and safer and usually works the best. And then if we get more refined and we play a little bit with it, we can see if it's a lateral flexion that actually helps to pull that disc away from that particular nerve.
Well,
and again, that's just something I get a little fussy with, depending.
Yeah, and that story I was telling you just a minute ago about the client who had the multiple conditions, and she came in with a hip hike that was higher on one side that bothered her after 5 miles of walking. So it tells you she was an active woman in her mid-60s. But that hip hike we found was actually doing that lateral flexion for her, because it was creating additional lateral flexion on that side, which was pushing the disc into the back, or pushing the nucleus pulposus back into the disc, and it took pressure off of that. But if we tried to correct that too much, it angered it. So there are times when we really have to look at something and say, okay, do we really want to correct something that traditionally, if we saw in a perfectly healthy individual, someone who has no issues whatsoever, say, oh yeah, we can do these things to stretch this area out, strengthen the other side. Oh, no problem. That'll take care of itself. Well, you could be asking for it with someone who has a disc issue.
Or just, someone who this is a protective habit they've developed over time that is working for them.
Yep.
And, in some idealized universe, and coming from the Pilates world, sometimes we get into this idealized universe, you think, well, if I can just balance the whole system out, it'll all be fine. Well, maybe. But again, mid-60s, seems to be able to walk 5 miles without major issues. That alone says they're doing pretty darn well. Like,
exactly.
I don't want to mess with this system. You want to see, like, am I overdoing this correction? I had a client who had, honestly, an exceptionally rare kind of muscular dystrophy situation going on. She also had she was Russian, and she'd had some kind of major back surgery. She had a really big scar on her back, and was super, super stunningly tight in her erectors. And it was the same thing. It was like she was very lordotic. She was very, very tight there. And I could only stretch her so much or I would irritate the nerves. And I think there was scar tissue around the nerves and other kinds of issues going on. But in her case, it was the same thing. It was like I could go a little bit towards extension, or actually in her case, towards flexion, but I could not stretch it hard. I had to just do whatever she could completely maintain within a comfortable range. No external pressure on it, just like what she could almost passively just do sitting or doing a little cat-cow, that she could do. Anything where, like say she was holding on to something and rolling down against resistance would cause irritation. And it just wasn't worth it, you know? So we just worked with trying to maintain her slight lumbar lordosis, which kept her pain-free.
Yeah. And we talked briefly about the McKenzie exercises. And really, we're just talking about extension. We're just talking about various ways to put the spine into an extension position. And, in Pilates, I mean, we talk about the swan, and some people can do a full swan and you see them come all the way up. And I think that's beautiful. And I am so envious. It's unbelievable. My spine, I don't think ever did that. That's okay. But even just having someone come up into, a modified, cobra position, or just on their elbows into a little bit of extension. Yep. Whatever they can do to provide that little bit of relief on the back can make a huge difference.
I've even found with some of my clients, I had this couple of clients where I had a really positive experience that way. They really just lay prone and relaxed.
Yeah.
Like that for a couple of my clients was enough extension, especially if they could relax into it and actually let their belly kind of sink into the mat, let their back sink a little bit.
Yeah.
A couple of times, you always try different things and see what works. And with a few clients, they would lay down, they would breathe for 4 or 5 nice deep breaths, really try to relax there. And that what was clear with them was an immediate relief, that nerve pain that was shooting down one whole leg which is called centralize. It would come out of the foot, out of the calf, and kind of maybe end up more in their butt and their hips, but it would really move out of the leg, and they would feel that relief fairly quickly just from even being gently prone. Then other ones, again, a small, like an elbow swan or whatever, just like being up, like you're watching television or whatever, and can sometimes do it too.
Yeah, I call that the Sphinx position, where they're up on the elbows.
Perfect. Yeah.
And it works. And for me, a lot of times I'll make that their rest position if they need extension. So I can do an exercise where they're in a prone position, and then, okay, come up onto your elbows. We're going to rest here for 30 seconds.
Yep.
So they don't even realize that they're doing an exercise necessarily, but it is taking the pressure off. So it's an easy way to sort of sneak that in between when they are resting between.
Absolutely. So there's the other thing I always think about with disc issues and with any kind of low back issue or sciatic issue is we're trying to decompress the spine, right? So we're trying to pull the disc away from the sciatic nerve, but we're also trying to engage the muscular activation around that whole lumbar area, both the deep muscles, multifidi, and the deep spinal muscles, the erector spinae, our abdominals, like really the whole system, to create that axial elongation, to get that little sense of lift, right? So you're actually creating more space between the vertebra so that disc isn't squishing out, or those vertebra aren't squishing closer to decrease the space between them, which also puts pressure on the nerve, right?
Mm-hmm.
So all that sense of lifting and elongating and trying to create more length, and all those images too are very important there. And that's that core engagement, right? That basic one-to-one transverse abdominis, multifidi, pelvic floor, diaphragm working together to create that lift and that length.
Absolutely. No, absolutely. Something to think about too that is going to get a little advanced and to think about is, what do we do for the client who has a multiple because a great example is I had a client who, when she first came to me, disc herniation, she was, late 40s. But the disc herniation was really the root cause of all of her pain. And within probably a few weeks, 6 weeks total, she was going to go on a huge trip, a lot of hiking and all of that. And we got her to the point where she was pretty much pain-free. She went to the Galapagos and she was doing incredibly well. But I worked her almost purely in extension and showed her how even standing to arch your back and all of this. Well, a year later, she came back and I was working with her regularly. What I noticed was I could see the apprehension sign occasionally when she would do certain exercises, and I kept her in extension because that's what was working. And she said, well, the pain has been different, but it's still there. And what we found was the discs had settled back in and they were comfortable, but she did have a little bit of stenosis because she has arthritis, age-related, that now she needed a little bit of flexion. And just teaching her that, suddenly she's like, oh my gosh, now the pain's completely gone. It's like, all right, we chased one way, now we got to go the other way and try and figure out what's going to work. So when you do have someone who has those multiple conditions, I hate to say, it's chicken and egg. You don't know which one is going to help alleviate the symptom of sciatica best.
Right. Right. I love that story, Brian. That story of progression, right? That you go in one direction for a while, and that gets you success in one area, and then you kind of almost like you unwrap the next area, right? Because stenosis and arthritis are going to be more irritated by extension, which weren't being irritated before because she was probably in more flexion causes. And then you kind of have to walk that path, and it really is like, and for me, I always think when you're a good practitioner like you are, it's that paying attention. Like, okay, well, I've really been focused on extension to get her through this trip, and it seems to have been working, but we're not getting as far as we can get. So what am I missing?
Yes.
Right? What's not working? And then you say, okay, well, let's try a different approach. And that's really one of those things that flexibility of mind is just so critical to successfully working with anybody with low back pain.
Exactly. And when you have someone who has the multiple conditions like this, and you are walking that fine line, neutral may be the perfect position for them eventually.
Right.
It may not, it definitely wouldn't work on this woman. When I first saw her, she needed the extension. And then, it's like the pendulum. It swung a little too far to one side. So it's like, okay, got to come back, got to come back. Oh, now it's swinging a little bit too far to the other side. Okay, we got to come back. And eventually you can find where that happy balance is. And you can, can keep them there and teach them where their happy place is for their spine.
Right. And it may be slightly extended. It may be slightly flexed, right? Again, it's the neutral zone. And in a lot of ways in this situation, neutral is the best position for that back and also in that position.
Yep.
Right? Because seated is very different than standing.
Yes.
And sometimes clients need, support in seated, like I've had a disc injury and SI stuff forever. And I have to sit with some extension. If I sit in flexion, it'll just start to bother me over time, one way or another. So for a long time, I used a little pillow behind my low back. I have a kneeling chair, like I have accommodated for years to staying in slight extension when I sit. And that works. Mm-hmm. But for other clients, like I think about my stenosis clients particularly, where there's age-related changes, you're not necessarily going to change the bones. The bones are doing what the bones are doing. for a number of them, they've had to remain in some flexion. That's it. Like their position is going to be slightly posteriorly tilted, slightly flexed, and that's the position that's going to work for them when they're walking, when they're sitting, when they're in bed, and they just have to do that for pain control in that situation.
And in my case, I do have the two. I have a multi-level disc herniation, but only when that bothers me does extension work. Otherwise, I've got arthritis. I've got facet joint syndrome and back there. So extension bothers it. So it really is that fine line. And I know when one's bothering me, okay, I got to work on extension for the next couple of weeks. Then things will calm down. Then go back to a little bit of flexion and find where I need to be. So it can be very tricky when you're working with a client who has multiple conditions at the same time. And one of the things I find is if they tell me they have a disc herniation, I still ask them, did the doctor ever tell you to lie down and put your feet up in the air or to put pillows under your knees? Because everybody's heard of a disc herniation.
Right.
You try to get someone who doesn't know anything about the body to say the word spondylolisthesis or stenosis. They don't know what you're talking about. My dad's a great example of that. He had no idea. And he said, this long word as I don't know. And I said, spondylolisthesis. He was like, that's the one. I was like, all right, now I know how to work with you. And so but they knew the word herniation, that's what they told me. But then when I talked to the doctor and the doctor said, oh yeah, we want, them to be in flexion. I'm like, oh, but that's opposite. So if I just say, what position did the doctor tell you? Did he tell you to put pillows under your knees? Did he tell you to lie down with a flat back or with your legs up? Oh yeah, he wanted me to do that during the day, whenever I could. Okay. That's going to be sort of that first indication in my mind that there may be more than just the one thing that we're looking at. And I'll try and talk to the doctor. But it's a good way for me to have that indication of we're probably seeing more here than meets the eye.
The other thing, exactly. So again, it's just paying attention and really looking and listening closely. What makes you feel better? What makes you feel worse? What have you been told to do before? And paying attention is one of the key things there. A couple of other things is one challenge that I always want to bring up with sciatica is hamstring stretching.
Yes.
So just because what I find with a lot of clients with back injuries of all kinds is they always want to go into a kind of a forward fold or hug their knees into their chest. Like, oh, it feels so much better when I hug my knees into my chest or lean forward and stretch out.
Yep.
Because that can provide temporary release of just back tension. But with a disc problem, that is more likely to irritate the disc, which again, the muscle tension may make you feel better briefly, but then the disc thing will often, pop right back up very shortly after that. So one of the challenges I always have with particularly my disc clients is you don't get to do that. You don't get to just lean over, stretch, like that. Oh, I'm reaching my arms forward, I'm stretching my back out. Like you just don't get to do that for a little while, which will drive them nuts. But that's something to think about. And that goes with this idea also of hamstring stretching. And you mentioned it earlier. When you stretch the hamstring, you are pulling directly on the sciatic nerve, right? That's a lot of you're stretching muscles and tissues, but the sciatic nerve is embedded in all of that. And one thing about a nerve irritation is sometimes with nerve irritation, you can also get a little bit of stickiness between the sheath around the nerve and the nerve itself. And that means that when you go to stretch that, you may, break some of that and cause some local inflammation between the nerve sheath and the nerve. And that can lead to some irritation as well. The other thing too is if you're doing a hamstring stretch, you're just pulling directly on that nerve, which may alone be causing some irritation. So, if oftentimes I do need to do some hamstring stretching with a client with disc problems, but I make sure I do a lot of things. So one thing is I will usually use something like a lumbar roll or something under their back, something to keep their low back stable, because most people, when they do a hamstring stretch, move into lumbar flexion, right? Unless they're very specifically coached. And even if they're specifically coached, I will tend to use a support there because I don't always trust that they're going to keep that area neutral. And so that you really are trying to keep that stretch almost between the sit bone and the back of the knee rather than going up into the hips or the back at all. And it's also something where with all of my sciatic clients, I will test that hamstring stretch just gently, like not necessarily the first session, but after a bit, I'll say, okay, let's just try a little hamstring stretch. We'll just go into it briefly. We'll come out. We'll go into it. We'll come out of it. We'll come into it, come out of it. See how you do today. See how you do tomorrow. See how you do the next day. If we had no extra problems, no flare-ups that I could tell were from that, then it'll be like, okay, so let's try to hold it for 10 seconds or 15 seconds. Okay, let's see. We gradually build up into it. Because sometimes you'll do it and they'll be fine at the time because they're all nice and warm and everything's organized. And then 2 hours later, they'll get a flare up, or that night they'll get a flare up, or the next morning they'll wake up and they're like, oh, my hip really hurt or my hamstring really hurt. So just some things to think about too, in terms of with nerve symptoms. Sometimes they're immediate. A lot of times they are not.
Sure.
A lot of times you will not know what you did until, again, they drive in their car for a half hour home. So they're sitting and then they get out and then it hurts, or the next morning it hurts, or later that evening. So I always say with any disc problem, okay, how are you today? How are you the next day? How are you the day after that? Because that gives me a better clue about how they're responding to what we did than what happens just in the session.
And something to think about too when we're talking about just the stretching of the hamstring is if you bend the knee, you're no longer tractioning that sciatic nerve as much. So even just bringing one knee into the chest can provide a lot of people with enough hamstring stretching that they feel some relief. And if straight leg bothers them, if I'm trying to get them into a straight leg position and do a hamstring stretch and that bothers them, just bending the knee 10, 15 degrees can be enough that it's going to relax the nerve, not traction it nearly as much, and you'll see, oh, okay, this works. They're not getting the numbness tingling in their foot or their lateral calf or wherever it was. So that in and of itself can really make a difference.
Perfect. Yeah, absolutely. Good point. Very good point there. So we talk about axial elongation. We talk about a little bit of the extension work. We talk about, being careful with hamstring stuff. I think really this gets back to all of our core principles of working with dynamic lumbopelvic control or lumbopelvic stability. Lumbopelvic stability, the whole concept of it, and all the exercises around that, our marching and all of our work that we do to organize that area, are really come from the idea of working with disc issues. I think that's where I always see a lot of that stuff coming from, and understanding where your back is, where your hips are, and what the best position is for you is really critical for any kind of disc issue.
And I think you just said it best. It's the awareness, because sometimes people don't even realize that where their body is in space. I mean, we all have clients like that. They don't know where their body is. They have no clue. And if you get them to lie down and even do a simple march or even do something very simple where they're feeling where their body is in space and just saying, okay, just let's keep your pelvis still in this position for now, but be aware of where it is. Keep that awareness, and then we can move it a little bit. We can get more dynamic with it. But teaching them that awareness so they know where they're at, I think it makes a huge difference.
The other thing too is this is really with sciatica. I often look a lot at how they're sitting, their ergonomic situation, what they're doing when they're driving. Even with I'm thinking one of my clients, I really wanted them to give me a picture of their couch, because they're one of these people that basically, did pretty well during the day. They had a fairly active job, so they weren't sitting all day, and they did pretty well. But they would come home and they would always come and tell me all the things they're watching all night on television. The movie I just saw and the series that I'm binging and that kind of thing. So I'm thinking, okay, so you're spending 3 or 4 hours potentially in whatever sitting situation you have at home. And, so that I said, okay, I want your partner to take a picture of you sitting at the couch. Right. And they did. And they brought it in. It was like, okay, this is your problem. Right. It was the full slump. Their low back was squeezed into the couch. Their head was forward. They were sunk down in their hips. It's like, okay, so we need to change that. You need to change your chair, right? So things like that. I was always looking a little bit deeper at if there is something else going on.
And something else to think about that you just reminded me of, in bed. Because think about it, how many of our clients do want to read in bed or do computer work in bed? Or I remember during, the pandemic, people taking Zoom meetings, lying, sitting up in bed. And I'm thinking, are you crazy? That's just making your condition so much worse because you can't get decent posture lying in a bed or, sitting up in a bed. Yeah.
If you are really flexible in your hamstrings and your hips, maybe you can, and you got pillows here and everything else, but you never do. You're slumped, right? You're leaning back. You got a pillow here. You got something there, and you're rounded in your back. That's
exactly
what you're doing.
Yeah. So that's something else I think about and you said it. What you said was perfect. During our sessions, how many times do we hear from our clients, all about what they're watching and they're doing this and they're doing that, and you hear about everything that they do. And if we put 2 and 2 together, we might be able to figure out, oh, you're spending a whole lot of time in a seated position watching TV. Okay, maybe let's take a look at what you're sitting on, how you're sitting, that sort of thing. And then, where are you at work? Ergonomics. Well, people have done ergonomics at work all the time. How many people, though, are working from home multiple days a week now?
Yeah.
And I bet they're not looking at ergonomics the same way they did in their office.
No, on a dining room table.
Oh, yes.
I mean, especially in the pandemic, it was like whatever surface you've got some random chair, you've got some random desk.
Bar
you
stools.
Can't afford one, right? You're working at your like bar stool counter. You go to Target and you buy whatever chair you can for $98 or whatever. Yeah, and you end up with your keyboard up here and your chair down there, and your monitor, and you're working on a laptop, so you're hunched over.
Yep.
It's a nightmare.
Oh no,
so all those things.
They make such a huge difference. And the car, getting in and out of the car.
Yeah.
I mean, I think you were the one who told me that you had a client who had a small sports car and would drive it around for the weekend for fun.
Yep.
But then come Monday, had incredible sciatic pain because he's so low to the ground and so slung under.
Yeah, and because his hamstrings were so tight that for him to sit in that sports car, he could not be neutral because the seat is like 6 inches off the floor. He's got his foot on the pedal. His legs are basically straight, more or less, in front of him with a slight knee bend, and he didn't have that flexibility.
Yep.
He could barely touch his knees from a lean over. So, and he would drive down to LA and back every weekend, which is like 6 hours. Yep, and you wonder why his back hurt. And I was like, well, that's why. Yeah.
I've actually had, that's just it. I've actually had clients who came to me, saying, I'm having a hard time, I can't get comfortable in the car and everything. And I'll say, well, have you tried a van? Have you tried an SUV? Have you tried something where you're sitting more like a chair with your feet, with your legs down instead of straight out in front of you? Because that can make all the difference in the world. It did for me.
Yeah.
I wondered why, when I used to drive a pickup truck, why that was the most comfortable chair. I could spend hours driving. It was so comfortable. And then I got into a car afterwards, driving my wife's car, and I thought, man, this is so uncomfortable. And I thought, well, no wonder. My legs are out in front of me, and I've got decent hamstring length, but just the positioning of sitting upright like a chair made all the difference in the world.
Yep. Yeah, I had many clients who ended up, when they could, changing their cars for that particular reason. They just realized it wasn't going to work for them. So the other thing that I like to think about with sciatica is sciatica often, like if you think about the sequelae of it, like how long it goes on and that kind of thing. You said your big toe's still numb. I've got a patch that's still numb on the inside of my right calf. It's been numb for years from the same thing. And it also can lead to long-term muscular imbalances. So if a client has had long-term sciatica for whatever reason, several months or longer, I often find that what I do an awful lot of in that situation is I do a lot of leg strengthening in whatever position they can take, however they can do it. I do a lot of leg work. I do a lot of hip work, and I do a lot of leg work, and I do a lot of calf work, and do a lot of footwork. Like I focus a lot on just strengthening that whole area. because I find that the healthier those tissues are, the less likely I find sciatica is to kind of be a problem. And you've got to find ways to do that don't compress the spine.
Mm-hmm.
Again, speaking from the Pilates environment, one of the challenges I found with my clients with really bad disc issues and sciatica is to be on the reformer with the feet on the foot bar and the shoulders compressed by the shoulder rests on the carriage can often irritate them with my clients who are in seriously bad shape. So we've really had to find ways to have them do footwork where there isn't the pressure on the shoulders or they're not being compressed from top and bottom. So for those clients, like I do, like on the trap table, I'll do a lot of feet-in straps. I'll even do some chair work. I've done even some like footwork on the tower on the trap table where they're just, they're pulled way back, so their legs are not in a right angle, and they're just bending and straightening the foot bar. And those have been helpful just in terms of finding ways to do essentially a squat as unweighted as possible. To try to get some strength going in the legs, because I do find that will deteriorate with long-term sciatica, and if you can get that stronger, it'll often help some of the pain and also just make them able to function a little bit better.
I've also noticed on the reformer, if I just have them scoot down just a little bit to take their shoulders just slightly away, it's not as much compression. There'll still be a little bit, and of course reduce the weight or the resistance to spring tension a little bit as well. So they're not being jammed up into the shoulder rests, but there's a little bit of space there because let's face it, we all weigh something. So we have some tension with our body, just friction that's holding us in place, that just by coming down, 2 or 3 inches can make a difference.
And I usually put them on a sticky pad too.
Nice.
the little shelf liner stuff. Because sometimes if they're a very light client and they got slippery clothes on, they're not going to stick. But I'll put something on there to see if I can stick them down a little bit more.
Sure.
Or else I have some little like Nerf balls,
Mm-hmm.
those little foamy or even just sponges that I'll put between the shoulder rest and their shoulders. So
Nice.
they'll start farther away, but they also won't push up into such a hard surface. So those are all also little ways to do that.
Yeah.
Yeah.
And I've got an adjustable table. So for me, and I use it mainly, protect my back when I'm stretching someone or working with someone. But I can take them, from a sitting to standing position, but I can raise it up. I can raise that height so that they're only going, they're only really doing 1/8 of a squat instead of, a full squat or a half squat, a quarter squat. And that's a good way to introduce that, begin to build that strength again. And then slowly I can drop it 1 inch a session, Start them up high and just slowly drop it until they're more and more comfortable going a little bit lower and a little bit lower. And I find that works really, really well because, everybody has to squat. We all have to get up out of a chair, but not everybody can do it comfortably out of a stool or a chair that's, 18 inches off the ground or 16.
Right. Yeah, so starting that, I do a lot of, I know I'm a Pilates teacher, but I do a lot of standing squat work with all my clients. Again, whether it's, and I'll have them like sitting down, up and down on the foot bar, for example. If I got a reformer in my studio, just come down the foot bar and come back. But it's not a very deep squat, but just down and up, down and up, down and up. Or on a box, on a moon box, or not a moon box, but a sitting box, or the chair, right? If they're sitting there in a chair, and a lot of times the clients I'll find, the ones who have real issues there or are deconditioned, right? Use both hands on both armrests to get up every time, and you really see like, and I want to work them, ideally with all my clients, I want them to be able to do a squat without having to use their hands. So that's just one of the things that I generally am aiming for. However, I have to slow, and it may be 1.5 years to build them up to that, but really working on that.
Yeah.
The other thing too, I find is I do a lot of ankle work too with a lot of those clients, because I find, when there's deficits of the legs or when there's been those nerve issues, a lot of times, to your point and to my experience, the area that's going to get sometimes the most affected by sciatica is the periphery. Meaning like the numbness in your toe or this numbness that I have in my calf. It's like those seem to be the peripheral nerves, the peripheral parts of the nerve seem to be more affected oftentimes, especially by long-term sciatica. And even if it's just a sensory deficit, like it is for you or it is for me, that still makes me feel like I want to make sure I keep the motor piece happening.
Yes.
Because that nerves respond to, and everything responds to work. So, I don't want to overload it, but I want to keep it loaded so that it keeps that stimulation going. The nerve stimulation keeps going. And, maybe I may or may not regrow that area or get the sensation back, but I want to maintain the motor control element of that nerve.
Something that I want to mention as well, when you're working with a client with a disc issue, that I've seen this happen a number of times, and it was told to me by a physician, there comes a point at which, if it gets bad enough that they're going to need surgery, it's just that it's going to get bad enough. One of the telltale signs is when that motor strength suddenly disappears, and they're going down a flight of stairs. And one of the questions that I started hearing more and more from physicians when they were talking to my clients is, do you feel like your legs give out on you going downstairs?
Mm-hmm.
Because that's sort of that first telltale sign that muscular weakness is occurring, and it's occurring at a rapid rate, that suddenly they no longer can control with that one side. And so, and, the story we've all heard about is, the person who ends up at the bottom of the stairs, it's sort of like, yeah, his leg just suddenly gave out on them.
Right.
And, like I say, not everybody who has a disc herniation may need medical intervention. But if the impingement is there long enough, we've all heard of drop foot. We've all probably experienced a client who has had significant muscular weakness because of an impingement that lasted an awful long time, that they need to have that disc taken care of. They need to have spinal fusion, laminectomy, whatever it is. But when you get to that point, now, what do we do afterward for that client? Because we're not good. We still want to generate some, sensation as much as we can. We want to get them stronger. We want to, they no longer have the impingement. But have you found that you're able to reverse some of that muscular weakness or drop foot or any of that?
If it depends on how serious the issue is. I mean, I've had clients with drop foot, and I wouldn't say that I've been able to affect the drop foot directly, but I have been able to maintain basically, I more feel like I'm helping the body to accommodate to that lack of support, right? Keeping the other leg stronger, keeping the calf muscles as strong, the calf muscles that are working as strong as they can be. If anything's going to compensate for that dorsiflexion, the toe extensors or whatever, kind of work on that. And use it or lose it is true to a large extent. So even if I'm not necessarily improving that particular deficit, I'm trying to let the rest of the body figure out how to manage that deficit as effectively as possible and maintain as much strength as is necessary to manage that deficit. That's how I'd put that.
And that's exactly what I've seen. The drop foot, I haven't been able to necessarily work with or correct, eliminate. And I've heard different things from different physicians, and I've read different things that the nerve can begin to regrow. I hate to use the word regrow, but re-stimulate itself. Slowly. I've heard, a millimeter a week, a millimeter a month. I think everybody's a little bit different in that sense. But the drop foot, I've never had someone reverse that. However, have I been able to get them overall stronger in that leg afterwards? 100%.
Yeah.
Without a doubt.
And we're able to balance. We're able to go up and down stairs. We're able to do stuff. Because balance, when there is something like drop foot, balance becomes a real issue because they're not even in their gait, right? Ever. And so trying to create the confidence and the support to be able to walk with confidence, even though things are not even, is really important because, the last thing you want them to do is fall down and then break something or whatever.
Exactly. I just wanted to touch on that because people will see that. And if it comes to you, understand that that's not necessarily something that you're going to work on to correct. That may be neurologic, beyond our scope of practice and beyond what we can do, just in general. But we can always work on strengthening. We can always work on some balance work. We can always work on whatever they've got, we can make stronger.
Exactly. And that's the joy of what both of us do, is taking a client wherever they are, whatever situation they're in, and doing what we can to optimize that and to make it better. And that's the joy of what we get to do, That's why I really like, that's the fun, is watching people improve. And to your point and to my point, we've gotten down the rabbit hole of fairly serious situations here. What I found, and I think you found too, is I found Pilates to be phenomenally successful at alleviating sciatica, at decreasing disc pain, and helping clients to manage the disc pain if they get it on and off. And it really, and a lot of it, again, is about teaching them how to manage it, because it is how they sit and how they stand and how they habitually do what they do, drawing their awareness to that, how they hold their body when they're doing whatever they're doing in their daily life. And that's what we get to do, is educate people about how to take care of themselves. And with sciatica, that becomes a discipline, honestly, for the client. Understanding what positions are most effective for them, which ones are going to cause them trouble, and minimizing as much as they can those that cause them trouble, and maximizing those that are beneficial.
Absolutely. And something that we brought up and mentioned a few times here, teaching that awareness first, so that they are aware of where their body is in space, but then beginning to teach that stability, that dynamic lumbopelvic control, so that they can move their pelvis in a way that is going to be most beneficial to keep them out of pain. And they can feel when they're out of pain. They can say, oh, I'm safer here. So eventually it becomes more natural for them. That it's
it becomes
secondary.
A reward. Right, you create a reward, like, oh, if I do this, I feel better.
That's a great way to put it.
And that creates the pathway towards improved behavior, basically.
Yeah, that's a great way to put it. It is a reward. You're right. Yeah, it's positive reinforcement. Whereas pain is negative reinforcement.
Right, exactly.
Oh, and I know we went down the rabbit hole a little bit, and that's what we're going to do. We're going to explore a little bit. I wanted to finish up on something. I wanted to introduce a new concept to the podcast, is for each of us to come up with either an exercise or an exercise strategy that we can give people who are listening to work with their clients or themselves, something simple that they can do at home. Do you have any thoughts on this? I've got an idea. Do you have any idea, or do you want me to go first so you can give us some thought?
For sciatica particularly?
For sciatica, disc pain, we can even sort of go into a little bit of that low back pain as well.
Okay. I think that's kind of an infinite number of questions, but
there's a lot we can do.
Honestly, so from the very beginning, a lot of times what I will start with. So I'm going to take this back a moment. One of the things that seems to be clear from research, and again, there's a lot of debate on low back research, but one thing that seems to be true is that with a low back irritation of any kind, that decreases the stabilizing component of the whole lower back. So the TA kind of falls asleep, the multifidi fall asleep, and those deep stabilizing muscles of the spine stop working as well. So that at least seems to be clear. So the first thing that I do really is I have clients, okay, this is all I want you to do after our first session is every time you're going to put an unexpected load through your back, opening your car door, getting into your car, lifting something hot off the stove, running for the bus. I want you to just engage your abdominals, just pull them in before you go off and do whatever you're going to do. So think about it like you're going to lean over and pick your shoes up off the floor, pull your abdominals in, then lean over and pick your shoes up off the floor. Before you leave here, that door I know is really heavy going out of my studio. You're going to pull your abdominals in and open that door. So actually, that's actually where I start, with a very, very simple, just start to think about engaging that core before you put a load into the spine.
And that's incredibly functional too, though, because you're teaching them for the long haul what they can do to keep themselves healthier and their back stronger. And for them to just generally engage their core better.
Right, and just be aware. A lot of it is being aware that you are going into a situation that may stress your back. You're just Let's say you're cooking, you're doing a lot of chopping. So you're leaning over, you're chopping, your back always gets tired there. Okay. So pull your abdominals in, maybe stand a little straighter and play with your posture as well in that. And sometimes, those I've occasionally had just those little tips make a huge difference for somebody.
Nice.
Oftentimes I need more, but they can make a difference. So I always start with something simple that they're going to apply every time they think about it.
My suggestion is similar-ish. And I say similar-ish because I wanted it to be functional. I wanted it to be something that everybody can do. And I'll tell you a little story of part of how I teach this. But it's how to get up out of a chair, how to get up into a standing position. So many times people with low back pain, and as I see people who are older, when they stand up, they use their hands and that's fine, but they sort of arch their back and they're actually trying to lift using their back rather than their legs.
Yeah.
So the first thing, and the story I tell my clients about this is my wife. After our firstborn, she had a C-section. And every time she tried to stand up, it killed her because they cut into her abdominals. She couldn't use those abdominals. So all I did, and I did this in front of the nurse, and the nurse said, "That's brilliant," is I said, instead of thinking of standing up, push your legs through the ground. Just simply push down with your legs and let your body rise up. And she did it, and she said there was no pain. And like I said, the nurse says, "That's brilliant. Why aren't we teaching everyone this?" And I was like, "I don't know. Why aren't you teaching everyone this?" So that is something that I teach almost everybody when they come in with any type of low back condition, especially a herniated disc, is because when they try and get up, everything is tight and they're already anticipating that pain. They can feel it before it ever happens, and we both know self-fulfilling prophecies.
Yeah.
So I say, just push your feet through the ground, like you're pushing down to the center of the earth. Push your feet down as you stand up, and 99% of the time they do it, and they say, "Wow, that didn't bother my back at all."
Nice.
So,
I love it. I love it. Because I mean, even just getting to and from your studio, right? They're going to get into their car. They're going to sit down, probably. I'm sure a lot of them arrive by car. I know they do out here in California. And they're going to get out of their car. And then they're going to go into their office or whatever they're going to do. So I think that's great. That's brilliant. And it's something like, I think any of these things, it's pay attention. A lot of what we're trying to do is draw our clients' awareness to something they already are going to do, and to pay attention while they're doing that. Because one of the things that I know and you know is you give clients a list of 3 exercises and they might do them. But they might not, right? And if you give them a list of 5 or 6, guaranteed they will not do them unless they're like a high-level performance-oriented athlete. Nobody else is going to do 6 exercises, or very few. And even with the motivation that'll make them feel better. So bringing these things into their daily life, like I'll give people things to do when they're brushing their teeth or they're waiting for their coffee. Like I'll say, the thing I like to do a lot, which may seem counterintuitive, but I will do a lot of like heel raises. If you're doing the coffee, do 10 heel raises. If you're brushing your teeth, do 10 heel raises. Because again, just that stimulation from the bottom, it gets the nerves going all the way up. It kind of gets the posture doing something different, and keeps just basic strength going in the lower body. So, just little simple stuff that they can do whenever.
Great. Well, see, that's exactly why I wanted to introduce this as a new concept for us. Is something simple, something that we can give people, and that the average person can learn and say, "Hey, that's very easy." And it's going to increase the function of my client's life, increase the function of my life. I just think that's the best way to do it is something simple, functional, and easy to reproduce.
Yeah, absolutely. And something they don't really have any excuse not to do.
Exactly.
Right? I mean, because like I've given clients TheraBands, for example, for exercises, and the excuses I've heard, I don't have a wall. I don't have anything to tie it to. There's nothing stable in my house. My dog eats it. My children's it's like, oh my God, really? I really had somebody say, I don't have any walls in my house.
Yep, I've heard that.
Right? And I'm like, how could you not have, do you have a door? Like, can you close the door and use the back of the door? So people will find any reason not to do something if it's if it's even one step that's necessary to do it.
Yep.
If it's part of their daily life, they're doing it anyway, it's much easier to try to get them to do it.
Yep. Well, I think we covered a whole lot today.
I think so too. There was some good depth in there. Thank you.
Yeah. So thank you for listening. We really appreciate it. As always, our social media, please follow us on it. Instagram @Moving Convos, Moving Combos @gmail is how you can get a hold of us. And we will see you again next time.
Yep. Thanks, guys.